Family Medicine and Primary Healthcare Micromodules 2016 by Professor Carmen Wong. Approach to Undifferentiated Symptoms and Diagnosis Formulation by Professor Carmen Wong. Learning outcomes. We expect that you'll be able to differentiate different frameworks in diagnosis formulation. You'll be able to formulate a hypothetical-deductive approach to diagnosis formulation. You'll be able to synthesize your own approach to undifferentiated symptoms and to be able to differentiate important and urgent cases and in eliciting red flag symptoms. So I'd like you to think about what some of the differences are between primary and secondary care. So last year you've done a lot of your clinical work, your clerking in secondary care. I want you to think for a moment now in primary care, how is the patient population different? How about the symptoms they present with? Would they be different? What kind of medical conditions will we be dealing with in primary care? What aids do we have for examination and investigations? And who is available for advice and support? All this affects you as a clinician. And it means your perspective when you're consulting will change. However, you will find that you will have a different perspective and you will find some of the advantages of being a primary care physician along this course. So you'll see the logo for these modules is in the shape of an iceberg. And this is really to depict that actually a lot of the symptoms or treatments that patients are having or they're self-managing is actually below the water. It's below the surface. We usually don't have any perception of what this could be. Primary care is that first access point in which that they seek medical care. Now, in Hong Kong, this could be in GOPC or private general practitioners or family physicians. It could also be traditional Chinese medical doctors. It could also be accident and emergency or even emergency rooms in some private hospitals as well. You'll find before that they seek medical care, many would have tried perhaps some self-treatment or have had some advice from relatives or friends or patients that are like them. So this module is on the undifferentiated patient. So what is an undifferentiated patient? Well, undifferentiated patient is a patient with a health-related problem or a set of problems that are poorly defined, organized, or diagnosed. You'll find that actually many patients that come, they have had various symptoms over the past few weeks, months, days, and they can't make sense of it. And so your role as a clinician is really to help the patients describe their symptoms and to be able to organize and define their illness for them. You also need to think about some of the other processes apart from the biomedical aspects. So things like the psychological and the social aspects. How is that patient living day to day? What is he or she feeling about the medical conditions? All of this will help you make a provisional diagnosis and arrange an appropriate plan of management that is patient-centered, that's really appropriate to that patient in front of you. And your role is to help the patient understand and manage their illness. Now, one of the questions we need to ask when the patient comes into the room is, really, why is the patient presenting with symptoms today? And I'll bring you back to the health belief model. And really, it's not just with regards to disease progression or severity that patients come in. Sometimes some of the modifying factors, things like, well, if they were older, they might be more alarmed at a particular symptom. Or perhaps they're younger and they're exposed to social media and they could be able to see some news, or they've read up a study on a more recent episode that is like their medical symptoms as well. So their perceived threat of disease increases. Now the cues would be very different to each individual. It's important to take that into context so that you'll be able to assess whether or not the symptoms from your history taking is something that you're alarmed about, or is this some sort of irrational kind of fear that may be coming in? And that would mean that your management approach would be different. Also, how the patient is thinking about their disease and what made them come into your clinic would also impact their likelihood of compliance to your treatment. So things like, are they going to take the medication that you prescribed? I mean, did they come for medication in the first place, or was it something else that they were after? So all of this will impact on your consultation. Now I would want to highlight the family medicine approach to differential diagnoses. Now, it may seem obvious, but common diagnoses are common. And so therefore, these are the things that we're looking out for, because we're actually seeing a lot of patients, perhaps with a lot of vague kind of symptoms. And we actually need to think about, well, what is the probability? What's the prevalence in the community? What's this likely to be? Part of that common diagnosis, we might break this down into age and sex, using a demographic approach. So there are some diagnoses that are much more prevalent in certain populations. So for example, if I had said shortness of breath, somebody presenting with shortness of breath, it will be very different in a 20-year-old as to a 50-year-old what your differential diagnoses may be. The other thing to remember is that although many conditions that we see are possibly self-limiting, and may not be severe illness that warrants hospitalization, there are still important diagnoses not to miss. Now, these may be things that you have seen in tertiary hospitals and clinical specialties as outpatients, so that these are the ones that are perhaps rarer, infrequent, but you'll be negligent if you miss those, because they could be life-threatening, or that you may cause a delay in diagnoses. Next, I want you to think about how you formulate your diagnoses. Now, usually, the hospital kind of approach, you may consider all possible differential diagnoses. So you may have any sort of acronym. This one is a vitamin from vascular, infection, trauma, autoimmune, metabolic, idiopathic, and neoplasia. Or you may actually have adopted a systems review approach, such as cardiovascular, respiratory, gastrointestinal, musculoskeletal, etc. Now, often, perhaps in your previous years, you'll have diagnoses that you can think of that are fairly rare in the fine print, but actually they really impress the consultants. So think about which approach you actually use at the moment to formulate your diagnoses. Now, in formulating your differential diagnosis, you may choose a hypothesis formulation using a PST approach. So, as I explained previously, why we're looking at things like the demographics and common conditions is that the probability is higher, that this is most likely to be the diagnosis that you see. Next, how about the seriousness? So these are the ones that we really shouldn't miss. So what are serious and important conditions we really shouldn't be missing? Now, treatability. So this is slightly different. So not only are those important ones we shouldn't miss, so those are the ones that may be that they need acute care, that they need urgent care, but also the ones that we could treat fairly easily, that we could cure, particularly for acute illnesses, then we should also not miss those as well. So once you have some differential diagnoses, you may want to think about eliminating those, and we'll go on to talk about that. But also, where in the illness trajectory is the patient coming to see you? Are they coming to see you at the beginning of the illness trajectory, particularly for acute disease? Are they coming at the very beginning of that illness, okay? At which point is important to note, because they're likely to get worse before they get better. Now, sometimes they may have a background of chronic disease, okay, and they may be on this declining illness trajectory from their chronic disease. So all of this is really important in assessing the patient's potential for deterioration and for improvement. Uncertainty and risk. Now, actually, some of you will be fairly uncomfortable during this module. The reason is because in family medicine and primary care, there is a larger degree of uncertainty and risk. So in about 30% of visits, there possibly is no disease-specific diagnosis. And it may be that it requires further observation. It requires further monitoring before that disease entity is more obvious. We also deal with highly prevalent health problems that are not life-threatening, and they may be considered illness rather than disease. And so sometimes it may just be ill health rather than disease entities, although those also have treatments. So not all clinical presentations would lead to established diagnosis. And most undifferentiated symptoms at early stage actually come in with very vague, non-classical presentations. So how do we deal with all this uncertainty? Now, last year you probably, during your clerking, use a very traditional inductive process. So you usually took a history, you did all the examination, then you looked at all the information that you've gathered, and then you may or may not have had any sort of investigation kind of results, and then you sum all that up, and then you make a diagnosis, or some plausible diagnoses. Now, with regards to the short duration of time for clerking in family medicine and the risk and the uncertainty that you have to be fairly certain throughout that diagnostic process. So this is something that we use, the hypothetico-deductive approach. So what does this mean? It actually means that you need to start thinking about your diagnosis right in the beginning. Perhaps right from when the patient is walking into the room, you're already assessing, are they well, are they unwell, or do they look seriously ill? And then asking your history. And from then you're already starting to think about what possible diagnosis. And the process is then you're trying to confirm and refute that diagnosis by using evidence that you've gathered in your history and using much more focused history, examination, and investigations during that process. So for example, let's take a patient that comes in complaining of weight loss. What is the most likely diagnosis? And how concerned will you be? Should this be a 20-year-old female versus a 65-year-old male? So as you're thinking, you probably have a list of likely diagnoses. With that, you should align your history so that you're taking your history and differentiating between your different diagnoses, and you're ruling them in or excluding them from your final likely diagnoses. And you're prioritizing your history taking with regards to your past medical history, family history, drug history, etc., so that they're in line with those priorities that you've identified earlier on in your diagnostic process. So during this process, you're really looking for diagnostic cues. This could be in the patient history, this could be through your observations. It could be if you've known the patient in the past or looked at the case notes from previous knowledge. You may gather information from relatives that come with them, or you may have had clinical notes from other professionals. So diagnostic cues can be anything. It could be symptoms, signs, statements, patient's behavior, and they build up this kind of contextual picture of what you're dealing with. So, in summary, you need to form your diagnosis and hypothesis very early in your consultation process, and you gather information with a purpose, and you're directing that search so that you're selectively highlighting particular points in the history, examination, and investigation. Other things you might look out for are things that are new observations. So it may be an unusual presentation of a particular diagnoses. It may be a particular change in function, or it might be inconsistencies with regards to the symptom progression that alerts you that it may possibly be another diagnosis or an atypical presentation of a common diagnosis. Sometimes we see differences between what the patient thinks that they have and what you observe them to be. For example, with regards to pain. So the patient could be saying that they're in a lot of pain, but when you're seeing them and you're distracting them during the physical examination, the pain is actually less. So this might alert you to other factors that might be contributing to the diagnosis. And you make sure you're on this kind of like a cyclical investigation, as you will, of evidence to support your likely diagnosis, and you're refining that hypothesis all the time. Some of the things that are very helpful are things like red flags. So red flag symptoms are alert symptoms that indicate there's a more serious underlying pathology. So in using those, you're highlighting particularly those are to exclude those important and not to miss conditions. So look at the following. So what are the following red flags symptoms for the following conditions? Back pain or headache? What symptoms would you ask so that that you'll be reassured if they didn't have these symptoms that the patient does not have a very severe illness? Yellow flags, on the other hand, are psychosocial risk factors that may contribute or impact on the physical condition. So these can include things like fear, anger, depression, job dissatisfaction, family problems or stress. Now these might actually be exacerbating factors for the physical condition, or they might be reason why the physical condition is not improving, or they may contribute in another way. So in summary, this is what the history taking using that hypothetical-deductive method would look like. So within the history of presenting complaints, you're really eliciting the signs and symptoms and asking for associations that are actually relevant to the differential diagnoses that you're making. And you're making this line of thought very consistent throughout the rest of your history. So for example, past medical history, you may be asking relevant medical history or risk factors that is associated with your most likely diagnosis. You may be thinking about iatrogenic causes that might be causing the symptom, or that there might be anything within the family history that increases their risk of the condition that you're thinking about. Now, traditionally, social history, you may just be asking about smoking and alcohol. In family medicine, we're really trying to find out much more about the patient and how the patient is functioning in both at home, at work, and in the community. So we want to find out things like the baseline of what, their lifestyle would be. So, for example, their diet, their exercise, what's their work regime, how they're getting on with their family. And then within that framework, we're trying to find out, well, what is the function? What physical or mental capacity function is that affecting them, their current illness? So, for example, headaches may be preventing the patient from going into work. So that actually also gives you a cue to how severe that might be as well, and what the impact on their daily life would be. Other things within a systems review, we do less of going through a particular all the different systems. So systems review, we tend not to go through every kind of system such as cardiovascular, respiratory, to rule out any other problems, because in primary care there's likely to be other problems that may be again undifferentiated. But what would be important to note would be other chronic disease that you probably would have picked up in past medical history. And also you want to look at things like their social and psychological problems. So other things such as, are they a caregiver, etc. So what you then want to do is to frame your presenting complaint against all these other different comorbidities. To get a more individualized view of the patient, there's an acronym of R.I.C.E. So this makes you look at, one, why did the patient attend today? So this goes back to the health belief model. What were some of the triggers? Ideas. What does the patient think the problem is. So sometimes the patient may think, if they've had the symptoms for a while, then they may have a diagnosis in mind. Concerns. What is the patient worried about? What is the patient feeling about his or her medical condition? Expectations. What does the patient want from the consultation? Now, all of these gives you a patient perspective of the context of care that they need, or that there might be inconsistencies between what you think the condition is and what they need and what their expectations would be. So establishing the patient-centered context will help you to manage the patient because you're aware of what the patient is thinking about and what they actually want from the consultation. So I want you, in reflection, to think about, well, what do you understand about the differences between primary and secondary care? What can you do or not do that you've been probably used to or you took for granted in the hospital setting? And how would this impact the way you approach consultations in primary care? Knowing now the hypothetico-deductive method, how would this impact on the way that you consult or that you organize your history taking? How would you weave psychosocial aspects into your history taking? And why is this important? Lastly, sometimes we use red flag symptoms and we kind of hope that the patient doesn't have any, but how would you further respond if the red flags were positive? How would that affect your differential diagnoses? So that's the end of the micromodule, but actually the in-class exercises you'll see some hypothetical deductive interviewing in action, and you'll get a chance to get used to developing and prioritizing differential diagnoses and going through common errors that students often make in transitioning into this type of interviewing. You'll also get a video workshop and review later on where you take a history from a standardized patient coming in with an undifferentiated symptoms, where you will be able to use this approach, plus using gathering more of a social context and using R.I.C.E within the consultation. I would advise at this point to go through the slides again if you feel that there's anything that you want to consolidate. But the main point is to practice, because actually knowing these is not enough. You need to be able to demonstrate these skills in your history taking. Good luck.